and welcome to the Health Scrutiny Committee, which is just about to be live broadcast. So James, can we get the live broadcast going, please?
Yeah, it's just started.
Fantastic. So yes, good morning to all. We'll move very swiftly on to item 1, which is just to review the minutes of the last meeting held on the 11th of November 2025. We all had a copy of those minutes. That's right. Lovely. And can I accept the minutes as a true and correct record, please? Yeah. Lovely. Item 2, apologies for absence. James, do we have any apologies?
We have received apologies from Councillor Upton for other reasons, Councillor Simon Wright for other reasons, and Councillor Terry Cox for other reasons. Substituting for Councillor Cox, we have Councillor Jodie Stoll, and substituting for Councillor Upton, we have Councillor Richard Butler. Thank you, Chairman.
Thank you, James. We'll now move on to declarations of interest. So, do any members present have any disclosable pecuniary interests to declare? No. And do any members present have any private interests, pecuniary or non-pecuniary, to declare? No. Lovely. Okay, moving swiftly on then. So, item 4 is the first item for debate, which is about the impact of integrated neighbourhood teams on hospital admission and discharge. This item is to consider a report from the Integrated Care Board, which outlines the aims and progress of implementation of integrated neighbourhood teams, model for community care in Nottinghamshire, and the potential impact this has on hospital admissions and discharges. I would like to welcome the representatives from the Integrated Care Board, so Gemma Weissel, who regular attender, Deputy Chief Delivery Director for the ICB, and Fiona Callaghan, who's quickly becoming a regular attender, who's the Place Delivery Director. Could I invite you to introduce the report, please?
Yeah, morning everyone, and we're very happy to be regular attenders here, so no problem at all. This is kind of a 2-part report that you'll have in front of you. So Fiona and I will do a bit of a double act. So starting really with the hospital discharge process that happens in the acute hospitals. We wanted to give you a flavour of what happens, the work pre people leaving hospital, and then the role of integrated neighbourhood teams once they actually leave hospital. So just to give you a brief overview of what happens, discharge planning absolutely starts when a person attends a hospital and is then reported as being admitted. So once they are admitted to a bed, the team within the hospital start planning the discharge. And the point of that is really to ensure that as early as possible, they identify what the person needs when they go home. So it might be medical, social, it might be care at home, it might be formal community services, it might be support from the local authority. And that process needs identifying whilst they are in hospital. It's worth pointing out, so the vast majority of people who leave our hospitals every day leave with no ongoing health and social care support. So we have about 250 people every day that leave NUH and about 80 people every day who leave Sherwood Forest, and they might leave with a prescription or a follow-on appointment but no ongoing health and social care support. So that's the vast majority of people. Then we have people who go with community support, which might be packages of care at home. They might go to a rehabilitation bed, they might go into residential or nursing care, or they might go to a hospice or palliative care pathway. So all of these are dependent on the individual person, their needs and their ongoing support. So I've outlined for you in the report the kind of range.
No.
The range of multidisciplinary team who are involved in making that assessment, but also being clear that nobody leaves the hospital without being certified as medically fit to leave. So the doctors in the hospital will absolutely ensure that they are clinically or medically fit to leave before anything happens. There'll then be anybody leaving on a supported pathway will have a discharge plan, which will detail things like their medication, their care needs, any equipment that they might need, social care support that they might need at home, and any follow-ups that they need. And I think very much this is a health and social care and communities, as Fiona's going to highlight. We all have to work together. This doesn't work if this is just health working in isolation or social care working in isolation. We all work together, and it's every day. It's all day, every day that we do this. I think that's it from a hospital perspective. So I'll hand over to Fiona.
Thank you. Good morning, everyone. I do have some slides. I don't know whether I'm
just bringing them up now.
So yes, as Gemma said, the second part of the paper you've asked around integrated neighbourhood teams, and I touched on this I think last time I came in November about the developing work that we're doing. So really good to be able to talk with you here this morning. And as you'll be aware, integrated neighbourhood teams are a central part to the 10-year plan, but actually neighbourhood health is much, much broader. So I will touch on the integrated neighbourhood team developments. Somebody said to me last week that actually Claire Fuller, the Director of Primary Care for NHS England, said we first started talking about integrated care in 1961. So it's 2026 and we're still talking about it and still working together in terms of the benefit of our people. But in terms of our, you can go to the integrated neighbourhood team slide. So this one, yeah. So in terms of what we're talking about, it's everything on the tin, really. It's the widest range of professionals and community representation, voluntary sector, services working together hand in hand to provide a much more seamless period of care for patients and citizens. And we've been, we've worked in an integrated way for many years. In fact, when you talk to patients, they say, I can't believe you're not doing this already. But this is really trying to formalise it much more in a way in which we can identify patients using our data sets that we have across health and social care to identify complex patients that we can work together better and wrap around care around. So this is one part of 6 steps in the national programme, the first being working across geographies that are around 50k, improving access to general practice, improving the interface between our primary care and our secondary care colleagues, agreeing plans to develop integrated neighbourhood teams, which is the focus today, and agreeing plans to support more urgent care in the community. And also looking more around planned care, about how we can do more planned care like outpatient appointments in the community. So it's a big programme that we're just getting to grips with locally. Next slide, please. Lots of professionals say to me, well, what is it going to look like and how's it going to look different? And lots of this is a bit like, well, this is what we should be doing. So we're really trying to think about a team of teams. So we're not trying to think about wrapping services around patients, about organisational boundaries, but much more around the patient. So one team, we talk a lot about the team of team approach, and that's certainly some of the things we're seeing on the ground locally. Support and care that focuses on the person, not on the services that potentially we've got to provide for them. No matter where the patient speaks, we should be taking note of that throughout the different access points into health and social care. And specialist advice and guidance, making that a lot easier for patients. So when we talk to staff in particular, this is the kind of narrative we're trying to say. It really is about leaving your badge at the front door and working together for the benefit of the patient and citizen. So just to give, next slide please, just to give you a bit more of a flavour of the focus in the neighbourhoods. So just get the next slide. Thank you. So it focuses very much on complex care, so it really fits in well with the discharge approach as well. But we focused initially much more around proactive care. So looking at our GP data sets and trying to identify people who perhaps have been bouncing around the systems, who don't have a personalised care plan, who don't have necessarily the right arrangements to keep them safe at home. So whilst we're talking today about discharge, much of the work that we've been focused on, particularly since the middle part of last year has been around that complexity and proactive care. And you can see that we're identifying patients across the spectrum of our neighbourhoods in the county. We've still got some to roll out. And you can see the types of real complexity that we're trying to see, well, how can we wrap that care around it? And whilst we're looking at NHS data sets, we're also seeing cases coming from citizen advice services, from social care, and from social prescribing teams out there. So this isn't just about the data sets we've got in primary care, we try and put those together, but more around, well, what's happening in our neighbourhood and why aren't some of our people being managed in the best possible way? So I'm going to take you just into a little bit of process in terms of the next slide, please. So what we're doing is that we've set up what we call integrated neighbourhood team panels. So we get representatives around the room and we start talking about those people, not just in a medical or clinical sense, but a lot of the time in a social and behavioural sense, around what can we do better for this person? Why is this person being bouncing around the system? How can we avoid another hospital admission? And why are they going into hospital perhaps, or in acute services or general practice services as quickly as they can? So we're really trying to focus on that holistic assessment and care planning, enhanced communication. I don't really know who my social worker is, or I don't know the nurse I need to speak to. So as much as it is for patients, it's very much about that professional understanding and working together. And we've kind of lost that a little bit, I think, as we've become bigger organisations. It's very much about how can we intervene earlier, how can we focus more on prevention for these people, and can we coordinate that care, and what sort of professional support and learning can we wrap around. So next slide, please. So some of the things that we are seeing within the discussions is we're putting more services around that patient. We're referring people into different community organisations that can help support them, trying to get access to different medical approaches where appropriate, additional community nursing if that's not quite where it needs to be. Some of the things that were coming out around the cost of living crisis, around dementia and loneliness in particular, and about housing, or some of the things that are preventing people either from getting home or from actually enabling them to get into hospital and not being discharged as quickly as possible. So I just want to touch on a little bit of a case study for you. Next slide, please. And we've got lots of case studies, and most of these case studies are around proactive care. So I can certainly send you lots of those in the way in which professionals have worked together for the benefit of our people. But I really wanted to focus on one that linked into the hospital. And this is in the Broxtowe Integrated Neighbourhood team. And the Broxtowe team meets at Stapleford Care Centre. It meets face-to-face. It has a range of professionals from health, care, community, voluntary sector, local authorities. And it meets to discuss around 7 to 5 patients every Monday morning. And this patient was raised actually by a social prescribing link worker who'd been in contact with a local pub who'd had expressed some concerns about a patient. And I know it says unknown to GP services. I think what that means is they weren't actively receiving GP care, but they were registered a patient but weren't actually accessing some of that care. And when the social prescriber visited the man, it was really found him to have multiple unmet needs and referred him to lots of services. And actually the social prescribing link worker said, actually, we probably could benefit from more of a consistent discussion across a number of people rather than referring him into lots of different services. And so on that Monday morning, they discussed the person and created a plan. And you think, brilliant, but then it gets admitted to hospital. And I think this is some of the challenges that we've got, is that we can put the greatest plan together, but if we don't follow that plan, they end up back in hospital, or if that plan isn't quite as good as it needs to be. So he was admitted to hospital soon afterwards. But in the INT panel, we have a community geriatrician. And when she saw the patient in the hospital, she thought, hang on a minute, I've seen this person in the community. All of the things he's come in for don't necessarily benefit from being done here or seen here, and actually provided crucial information to the team managing that care to say, actually, we can move you out much quicker. We don't necessarily see a journey in the hospital for you. And lots of things were missing from his hospital record, not necessarily his general record, but certainly the hospital information didn't have everything that perhaps was discussed in the panel earlier that month. And I think what this shows is if we can get the right people talking to each other, and when they're going back into their interfaces can see how things work differently and how we can manage those patients a lot quicker. This person did get discharged, we think quicker than perhaps he would have done if none of this information and that collaboration had been known. So it's a really small thing, but it really shows the kind of opportunity that we've got. And across the county, we have got a community geriatrician service. We are looking to see how that can sit much more alongside the neighbourhood work. They work really closely with our care home teams to support people, but it just really shows the kind of interface, particularly from our staff and our staff working together. And in the appendices, you can see some of the work that we're doing around organisational development, because this is about culture and behaviour across our staff, whether they work in care or in health. And we very much focus on our individual agendas, what we need to deliver for our patient, and we don't always think about that wider holistic view. So we're doing lots of organisational development work with teams. There's a session actually tomorrow in Ashfield where health and social care are coming together to see how they can develop their team much more in terms of the skills and capabilities required for the population health needs at Ashfield. So it's really early days, but it's really exciting, and we get a lot of feedback from staff about this is how we've always wanted to work. This is how I did work in the 80s, and I really want to be back working like this now. So we've got a real groundswell, I think, of enthusiasm, and we need to be working with that to make this business as usual for our commissioning arrangements. Thank you.
Yes, thank you both very much for that introduction. It was very good, so thank you. I will now open it up for debate. Councillor Barlow, to lead off.
Thank you, good morning. Yes, can I just ask, obviously, have these neighbourhood teams reduced admissions and prevented people going back? Have you got any evidence of that? And what have you learned from the pilot scheme? Have, the results, what's worked, what hasn't worked, what challenges have you faced, and is there anything you think you'll change?
So it's really early days. We literally in July got in a room and got started. So we didn't quite have everything in place. So we identified the cohort and we're following that cohort. We are tracking that cohort, but we didn't potentially have a group of patients we could compare against. So we're kind of iterating our sort of understanding of how these are working. So that's why we're doing more case studies than we are around the actual data for now, because the case studies really bring to life the wider determinants, which is what I wanted to perhaps share with you afterwards. So we don't necessarily have the data as such yet. We are trying to track patients, so we're using the NHS number, and we're looking now to see whether patients in that cohort in Ashfield, how many admissions have they had, and can we attribute that back? So that's very much part of the work that we're doing. And actually on Friday, we actually were able to issue all the INTs with a log of all the patients technically suitable for this INT work. So that's definitely work in progress. We're getting lots of anecdote in that way, but I'd love to be able to show you a report that actually shows that. So that's something definitely we want to do. And the second part of your question
was the pilot. Obviously, what did you learn from that? And
so
challenges?
Again, we aren't really piloting it. We're kind of trying to get on with it we've had lots of testing of integrated care. We had a pilot in Bassetlaw, we had an integrated care service in Rushcliffe. Midnots did something called PRISM that everybody talks about. So we're picking all of those bits and trying to work that. What we're really finding is, do people understand what an integrated neighbourhood team is? Do they understand the who's in that team and who they can talk to? So the culture and the behaviour is really an important part, and that's something we're definitely learning. And we've done a session around how to access the patient details on the databases that we've got. So it's a lot of staff learning. But I think it's also about how our community partners are working with us, and the range in which patients they're coming across. So some of the learning is we have a cohort of patients that we've identified in the NHS, but we're doing actually in Broxtowe some testing of cases coming directly from social care and directly from community services. So that makes the analysis more complicated because we've then got to join it all up, but that's exactly what these teams are about. So lots of great learning that we are trying to capture. We do have a regular newsletter, and I'll be really pleased to share that newsletter so you can see the type of impact we're having.
And just ask the second question.
You can indeed, Councillor Marlin.
Okay. Also, can I just ask, so do we have enough of staff available for these integrated neighbourhood teams? Where are the staff actually being pulled from? Are they existing staff, or are they new staff that we're looking for? Are the people, you know, already in the position?
So this is where it's really challenging, and given the pressures that we do have in our system, particularly on urgent demands, we are trying to do this alongside keeping the delivery going, because we don't have additional resources to run services, double run services, and that is a challenge. So some of the experiences we're having are, well, this person needs a visit, well, I can't fit this person on my caseload for a visit. So that's part of where we need to get into this way of working. This has to be the way of working, and we need to change our behaviours and the way in which we operate, and some of our the ways in which we approach clinical care to work in this way. So it's not additional staff, but we are trying to reorient staff like social prescribing link workers, like care navigation services, as much as possible to wrap around the team. But it is very challenging, and what we say to particularly frontline clinicians is, if we can work in this way, we can keep that demand away from particular medical services. In the sense that quite a lot of what we're coming up with are not necessarily clinical solutions. They require housing or care or community support. So again, trying to work much more efficiently, identify those complex patients, and so improve the day job of the local teams.
Thank you.
Councillor Rich.
Borrowing from Councillor Barlow's question, sort of following it. So on the paperwork on the booklet, it says care navigation services and coordination meetings. Can you guarantee that it's not going to be wasted on management and middle management and administration? It's going to be paid for the frontline doctors and nurses in itself. Can you confirm that?
So care navigation is really important. We have lots of care navigation. We have it right across the health and care system. So there's something about how we do that as efficiently as possible. But one of the things, in order to protect particularly some of our medical and clinical services, is to do that care navigation and get people into the right services, so that we're not blocking up unnecessarily appointments potentially in general practice. And that's certainly why general practice is keen to be involved, because they see patients that they can't necessarily do the best for. So it's not a management thing. The care navs are an administrative function, but they are talking to the patient, they are getting consent, they are looking at the patient record, they're coming into that Monday morning meeting at Stapleford Care Centre and saying, this is the patient, these are the issues, and we're trying to rapidly go through those patients, because again, we're using clinical resource for that discussion. So it's all about how we do that efficiently, so that patient then doesn't turn up in an appointment somewhere else. So I can't absolutely guarantee that, but that's absolutely the direction of travel.
Councillor Stoll.
Thank you, Chairman. Thank you for the report. I really enjoyed listening to that, and I certainly see the benefit. What I'd be interested to know, though, is there's been previous sort of integration models before, and it's always been something that we would aspire to. But really, what is genuinely different on the ground? How would, you know, a resident, patient, whatever, how would they know the difference from this model to a previous model? What real differences would be seen?
So that's a really good question. We deliberately haven't done any direct communication with the public, because we are literally trying to get our act together with this. And I think what's different to 1961 is that we've got absolutely amazing data. The data that we get from health and care that comes through our strategic analytic intelligence unit is amazing. And what we can then pull off and identify and really focus on is unbelievable, really, which is why we can really get to the people from an NHS perspective, the right sort of conversations. That's definitely different. I think there is, people recognise how they worked before, and that is really It's dissipated a lot, but lots of frontline staff want to work in this way, so they are actively supporting that way of working. Hence, we need to change commissioning arrangements in order to do that more effectively. And I think nationally, the movement is much more towards moving things out from the hospital into the community. And if we don't have our teams working culturally and behaviourally together, we've got no chance of transferring care into the community. So we really are at a kind of stars aligned moment. The finances are horrific. And lots of people say you can save money by moving things left, right and centre, but all the evidence says it is more expensive. So we've got to be really careful that we're not just shifting the challenges into other sectors of the health and care community, but that we've got a real momentum around this. And I think the role of the Health and Wellbeing Board in helping shape this is going to be super important.
Thank you.
Sorry, Jay, can I just add on to the role of the Health and Wellbeing?
You can indeed, Viv,
Thank you. So for those of you who don't know me, I'm Director of Public Health and Communities. And just building on what Fiona was saying there's a lot of work being done within the Health and Wellbeing Board around building on already some really strong foundations around integrated neighbourhood team working, but really extending that ambition around how do we develop almost an integrated neighbourhood public sector. Because what Fiona and Gemma have articulated there is that many of the factors that are wrapping around these individuals are not necessarily just healthcare and just social care, because we know that actually when it comes to your overall health and well-being, only actually about 20% of your overall health and well-being is linked to access to health and care services. The rest is around those, what you'll hear me talk around a lot, which is around those building blocks of health. So have you got a good, safe home? You know, have you got communities that will support you? Have you got a good job that's good for you? Have you got the right skills? Have you got the right access to services? So I suppose what I just wanted to build on is obviously there's a lot of work going on, particularly with our health and social care colleagues, really looking at almost the top of the pyramid when we think about our population need. And we're really thinking around how do we extend some of that ambition to start working into almost the lower levels of our population who may be just on that brink where if we intervene now, they might not need to access those health and care services in the future. And some of the work that we're doing here is linking into the ambitions for the Health and Wellbeing Board, really genuinely thinking about how do we work at a hyper-local level in a different way. And I think that is something that will feel different for our people in Nottinghamshire, because there is a genuine wraparound in a different way to how we've done it previously. And that's very much the ambition that we want to build and grow on. And there was a discussion at Overview Committee last week around the Thriving Communities programme of work. And that's specifically, it's more internally led at the moment, so it's more council based at the moment. But that's really thinking around how do we build on some of the work of the INTs, but wrap around our prevention, early help, voluntary and community sectors to strengthen that sector so that we can hopefully do more work around that prevention and early help. So if you would like to hear more details around that, we can circulate that report. I'm very happy to have some more conversations around that. And there will be a working group that's going to be supporting from Overview, that's going to be supporting the development around some of that thriving communities at work, because as local government reform comes, we know that this is one of the key things that we want to be building on. So it's building on great foundations, but really thinking around how do we do more of that left shift into prevention that will hopefully then reduce the level of need for those particular multidisciplinary teams in the future.
Oh, thank you very much for that, Viv. Councillor Butler.
Thank you, Mr. Chairman. This is really interesting because it's so important, and thank you for the information. I think you used an expression that I wrote something down here: support for the patient and not the system, which is fundamentally is what we're all about, isn't it? So one would perhaps expect to have that ethos. And you mentioned as well that because it's still quite new and you're going to get feedback from staff. What about feedback from patients and their families? And also, how sure are we that the patients and families actually understand what's going on? Because when you're in a hospital or a difficult situation, life is frightening enough as it is. And also, just one other sort of question is in your report, you talk about the hospital discharge. Now, I guess, is this all linked into what we often hear about bed blocking? Is it all linked into that, where or partly linked into bed blocking that we read and hear about? And one of the issues I seem to recall from years gone by, and I wonder if it's still an issue, but I don't see any mention in the report, is patient transport. Do we get involved with that? So sorry, it's a couple of questions, but thank you.
So yes, we are very focused on organisational boundaries and form. I get really hung up about the form all the time. So yes, so we want to try and work not within those forms and give people permission to work differently within the bounds of the neighbourhood. That's definitely the aspiration that we want to work to. As I said earlier, we haven't specifically done any communication with the public on this, and we need to be. So we need to be designing this with people with lived experience. So it's definitely something the teams are looking at. We've got a lot of case studies. A lot of the case studies we've talked to individuals and families, but again, it's very individual and small scale. So every time we get a bit of a success, or not a success, we're talking to those patients who are directly affected by that. But we need to do that much more systematically. And some of the work that we did prior to this was around local design teams. And one of the really good thing about that was it was much, much broader than the NHS. And we were getting community leaders and carers groups and people being part of that. So we've kept those groups going and are working with those locally in Gedling or Broxtowe to some of that. But we are looking at the patient engagement side of things now. Now we've kind of got almost up and running. We are looking at how we can then start to shape that with patient need, but also not just shape it, but get the feedback in terms of how this is working as well. So we haven't got that right at all, but it's definitely at the forefront of the thinking.
And the transport side of things.
Yeah, so just to pick up on the final couple of points that you made. So you're right, we did hear a lot years ago about bed blocking, and of course there are delays in people leaving hospital, because if you look at the report and the range of pathways that patients go out on, it could be that a residential home isn't available that day or the next day. It could be that hospice care is available later that day. So it's a jigsaw puzzle all day, every day of meeting the demand in the hospital with the capacity that we have in the community. So it might be rehab needs, it might be palliative care, it might be equipment. But you're right, we do hear less about bed blocking, and I think that's an improving process as we try and match that capacity and demand all day, every day with providers to get the right people out as quickly as possible. And then transport. I still get daily escalations about transport from the hospitals. And again, we try and make sure that only patients that need transport go in funded transport. So the vast majority leave without any ongoing care support, and transport is absolutely included in that. But we need to make sure that resources that we've got, if patients need a stretcher transfer, so if they're going from a bed to a bed, that they go in an ambulance and that they're transported in that way. And again, it's everyday escalations of, have we got the right people leaving hospital with the right support? Transport is very much part of that. People can go home with friends and family, great. Because that helps us to make sure that the resources that we have got that are funded in the NHS are for those that absolutely need it. So every day we continue to try and improve that process.
Thank you.
Councillor Dodds. Thank you for the report. It was very interesting. I've got 2 or 3 questions. You mentioned senior healthcare people certified as fit for discharging across a board of professionals. In the process you mentioned home to no additional support, home with community support. There's no mention of anybody who's homeless who may have come into hospital here and what support and how that would look. I'm curious to know what we could do for that as the weakest people in society, perhaps at different times of their life. You mentioned additional community nursing. Where would the funding come from that? I'd like to know. And you mentioned social prescribing. I'm interested in how many people we have working who are the social prescribers and who employs them. Are they an NHS-based employee? Are they a charity? Is there a mixture? Thank you.
So just to pick up on homeless, we have a system call every day that includes homeless patients. So it might be homeless people that are in hospital and we are planning their discharge. So that process we would class as a complex discharge, because that requires a range of that multidisciplinary team to work with somebody who is homeless on where they go next, and it will be very much based on their individual needs. So it might be that they do need a bed, they need a step down bed from hospital to facilitate them going back to their community. It might be that they need hospice care, but they would be classed as a complex discharge, and we do review that every day with health and social care in the system. I think community nursing and social prescribing.
So I'm not sure about community nursing, but the social prescribing, we did share a summary after the last meeting, which indicated the areas, the organisations who were hosting social prescribing services. So I just wonder whether we can just dig that out. I haven't got the numbers to hand, but it's a range of healthcare providers in the voluntary sector who host the commissioning arrangements on behalf of primary care networks. So we have a set number of social prescribers aligned to population health numbers right across the county. What specifically was the community nursing question? Because I don't think I'd...
In the slide deck, you mentioned that there'd be additional community nurses into the INT. I'm just curious where the funding's coming from that.
So we don't have additional community nursing. We're using the community nursing resource that we've got, and as I described earlier, working in a different way. So we don't have additional capacity. It's about working with the capacity that we have. So apologies if I misinformed you there.
Yeah, thank you for that.
Councillor Wheeler.
Thank you, Chairman. So, the discharge rate, in a previous role, I went to Kingston last week with the discharge team and saw it in action, and the fast thinking and the rapid response, it was great to see. One that was raised to me by the team there was that with some district councils, is the lack of the temporary accommodation. So that's going to be a block for the one district council in particular. I say Ashfield, I might be wrong, so if I'm wrong, there was one that top especially. So is that still an issue, and what work are we doing with the district councils to actually try to get them to provide that accommodation? Because, as I say, that's been your team and the hospital wants someone stuck in the hospital just because there isn't that accommodation for them to go to if it's not suitable for them to go home. Thank you.
So I don't know the full answer, but we can get more detail for you if you would like. But obviously, as you've articulated, the housing authority, the districts and boroughs in the county, obviously has been moving to local government reform. There will be 2 unitary authorities, and then that responsibility will move into both of the unitary authorities, which will provide some opportunities for us to do things differently. In terms of temporary accommodation, we know that nationally and locally we struggle to have enough accommodation, and we know that within a number of services, certainly we see this with our some of our domestic abuse provision as well, that we are struggling because we haven't got enough move on accommodation to allow people to move through the system to then thrive into what will be their new homes. The districts and boroughs are obviously doing a tremendous amount of work in terms of the planning applications and basic planning around that, but that is their responsibility at the moment. So if we want to get a bit more information around that, then that's probably something we need to go to the districts and boroughs for. But please do be assured that as the county has a housing strategy, is really keen and engaged in terms of what is the county council's role in terms of supporting our districts and boroughs within that. And also that's coming through as a really strong theme in terms of some of the transformational work from a local government point of view. But unfortunately, we do acknowledge that this is a national priority as well in terms of building more homes, because we know that we've got increasing population.
Councillor Thatcher.
So I find it's particularly interesting being a Broxton councillor to hear how it works in Broxton. So thank you for filling us in on that. Just got a question about how these teams work practically, really. And how is, apart from the panel meetings that you have, how is the information about patients kind of shared so that all the team members know what the other members of the team, what their input's been, what their recommendations have been for this patient, or what they have done with them, and kind of how action points for the kind of the other team members fed back to them, like is there something like IT club or something. And then kind of going on from that, it says on that example about the consultant geriatrician recognise this man's admission. Does it flag on a system when, if he was to come into hospital, say that consultant hadn't been in hospital on that day, would his admission not have been recognised so quickly? Is there a way that people who are working in the hospital know that this is somebody that the INT are working with, or is that process kind of not in place yet?
Thank you, great questions. So practically, I spoke a little bit earlier about the care navigation. So we have commissioned a care navigation service, and we've embedded that into each of the INC processes. So it's in a sense home of the ring. So they do the bringing together of the actions and understanding how that fits together and follows up with that patient and links back with the patient. But what's really helpful across Nottinghamshire is the shared care record. And we now have that almost rolled out to all providers. We're actually actively looking at how the voluntary sector can have access to that, so that people could actually see at a high level what's been happening to that patient. And that is really groundbreaking, certainly nationally, and that really helps us understand what have other people done. Let's not duplicate what they've done, even outside of the INT work. That a clinician or a doctor can see, well, what's been happening to that patient? What have social care been doing? What has the voluntary sector been doing? So that is making a massive difference in terms of reducing the administration locally. So that's really positive and continues to develop in bounds, really. In terms of the flag, I mean, this is a really good point, because when we went to Washwood over in sort of East Birmingham, that's exactly what they did. A flag went to the acute trust, and they had a live feed into their INT saying this person's arrived. They had an open Teams channel, and they were literally real time dealing with that person. Absolutely amazing. So that's really what we should be doing in terms of, and some of the things we're talking to the ambulance trust actually about is how do they know that this person's in a sort of a care environment. I think the challenge that we've got is we're not really working this in real time yet. But that's absolutely where it needs to be. And if we've got this shared care record, why can't it be highlighted in the hospital so that they can contact the care navigator straight away? Why is this person suddenly coming in? So those are some of the real opportunities. And this is a bit homemade, isn't it? The way in which this is operated, but really sees the opportunity if we can get those people signals in hospital.
Okay. Back round to yourself, Councillor Bowler.
Thank you, Chair. Just a couple of queries, really. So sort of going back to the obviously discharge, and there's obviously trends in discharge delays. Now, I'm sure one of these is going to be around medication, having had experience of this myself. You know, the doctor discharges you at 11 o'clock in the morning, you're still sat by your bed at 8 o'clock at night. And obviously, is that something that you're looking into? And my other question is, obviously without sort of GPs or someone already being perhaps in social care, how are you going to identify people that would benefit from an integrated neighbourhood team without them already being flagged up somewhere else? Only because I've had a similar thing in my constituency recently.
Yeah, so just to pick up on the first one, so within the hospital, it's called TTOs, so absolutely prescriptions leaving on the day, given that the vast majority of people will leave with a prescription is the focus of the acute trust. So they've got lots of improvement processes internally within the hospital about how they speed it up. And I think the sheer number of people who leave either on a pathway zero, as we talked about earlier, with no support, or those leaving into supported, it is a large number all day, every day, leaving from our 2 acute hospitals. But from an improvement process, both acute trusts are looking at how do they speed up that internal pharmacy work within the hospital. It won't always be perfect, but they are working on it.
Sorry, just to come back to you on that. So over 20 years, I've seen no improvement. Is there any signs of improvement?
Yes, absolutely. Yeah, there is. it's a challenge all day, every day, in the same way as we talked about for transport, but they do try and make sure that particularly those that are leaving with care packages that might have a cut-off time, that their pharmacy and prescriptions are ready to go before they need to leave. So there are signs of improvement. It just remains an ongoing challenge.
And in terms of identifying people, so on one of the slides, it shows you the type of cohorts each of the districts have decided to look at. They've picked those because they've looked and seen the patients who are perhaps turning up at hospital more, not getting wraparound care. So they've identified a cohort that they think the local teams can deal with. And then what we've got is in a GP system, a system that we call eHealth Scope, we are able to pull out everybody who sits within that cohort. So that's the work of the care navigator. So there's a log in each of the INTs that says, here's the list of patients who could potentially benefit from this way of working. And then they prioritise that list based on complexity, based on some of the information in the patient record, to then either have a discussion, or actually we can deal with those outside of having a discussion. It doesn't always require a multidisciplinary discussion. So that's how we're identifying patients at the moment. We are refining that all the time because we recognise some patients that actually we're not able to make as much progress on, or actually we've lost a little bit of impact on some of these types of patients. So that's the beauty of the data sets that we're looking at and the role that we have in care navigation to bring the right people through. So the GP will know from the work that care navigation does who from his practice is being seen on that, and we involve the GP when it's appropriate for that medical discussion. Quite often we're trying to not involve the GP, we're trying to use the range of clinical professionals and bring the GP when it's absolutely necessary.
Thank you.
Councillor Stoll. Thank you, Chairman. My question's around accountability and failure. So essentially, if a patient is readmitted to hospital, who owns the failure? Would that be the hospital, adult social care, or the neighbourhood team?
I think that's a really good question. We don't talk about it in terms of failure terms. And we haven't, I don't think we've necessarily followed that loop round consistently. But certainly when we're talking about patients and looking at how many times they've been in hospital, it's about, why did that not go? Quite often they've got a care plan, they've got a respect end of life form, but actually it's not very good quality. So, or they might have been discharged with not good enough. So I think it's a range of issues. And I think what we're finding through this process is we have the right interventions, they're not really well embedded and of enough quality to prevent that hospital admission. So there's an awful lot of learning that we need to. The reason why we're doing a respect form is so that we've got the patient's wishes and we can link into that patient wish and avoid that hospital admission. And sometimes that level of detail hasn't been seen in the paperwork.
And then just to follow up, obviously there is a cohort of people that it is absolutely appropriate for them to go back in. So if they've been discharged and they deteriorate, actually some of those we want back in the acute trust to make sure that they get the right medical intervention. So it is a balance, and I think Fiona's really pointed out that actually there are a range of things that could happen once somebody has been discharged, and it's about identifying the what could we do differently. But absolutely there is a cohort that are appropriate and should be back in hospital. So it is that balance between both those that we could avoid if we had a better care plan or a respect form, and actually those that are absolutely medically should be in hospital.
Can I follow?
You can indeed.
Thank you. No, thank you for those answers. So, and I think this kind of links into Councillor Paccio's question around the data and the let's say all the different teams. Do they have access to the same data set as each other? So that really what I'm trying to establish is if, you know, I appreciate your point about, you know, a cohort of patients, and it is vital that they are readmitted. But ultimately, what we want to know is if this is going to work, how is this all being measured? And, you know, when something does go wrong, and as I said, I take the point about patients being readmitted, but in the case of where something has been missed, you know, who ultimately is owning that? How is that going to be reviewed? And, you know, because we always hear the same thing, well, you know, we'll review the processes and we'll implement such and such so it never happens again. But the reality is these things always happen. So ultimately, who is responsible?
So just going to your first point, so the shared care record, a level of the shared care record is available to a number of health and care providers currently, and that's increasing all the time. So they will see a level of that information. Ultimately, we've had a lot of discussion about data protection and ownership of the data. In Broxtowe particularly, Dr. Scullard at Eastwood wasn't happy about the way in which we were operating it. He's the Caldecott Guardian. So we've had lots of debates about that. We've also had an untoward incident in Newark where something got on a patient record inappropriately because of something the INT panel did. So all of those trigger a review individually in particular in that instance, in that practice. So there are mechanisms within that. Ultimately, it is within the GP record, but also it's also about the patient giving consent. And because we're using a care navigation service that's hosted by an organisation, they also have responsibility. So ultimately, it will be about what happens to that patient in what setting. But we've already had some, you know, great debate and some learning as a result. But if there's any untoward incidents, a proper process, as we do in health and social care, will be followed.
Councillor Butler.
Yes, thank you. It just occurred to me actually a query about the INTs. We have to get so used to various acronyms, don't we? Very confusing. But it's just come to my mind that in some area, I know these INTs are still being rolled out, so not everywhere's got them yet, and I saw the timetable, that's fine. But I've been slightly parochial just for a moment. I've got an INW. I can't remember that standard integrated neighbourhood or neighbourhood. I can't remember. Working.
That's a fast behind.
So were those introduced in targeted areas where there had perhaps been a pattern of significant problems? But if you don't know that, don't worry, it's not true or anything. But when we eventually get the INT in our area, does that replace the INW or does it work with it? I just need to be clear on what the difference is.
That's a great question, and as you can imagine, we have had a myriad of debate about this. So you're absolutely right. A few years ago, probably 2023, we got some innovation money from the ICB to do integrated neighbourhood working.
Yeah,
and you're exactly right, it was in targeted neighbourhoods. So it was Cotgrave, it was parts of Gedling were in there, Ashfield, Mansfield, Newark and Sherwood and Bassetlaw. And that was brilliant because it really brought together, as I said before, the widest possible building blocks of health, the people who are absolutely supporting those cases outside of a medical perspective, and we absolutely loved it because it was much broader. So the way in which I describe it is much more broader about the wider health determinants that impact on people's health. What are the organisations got an interest in supporting that? And we are still using that as a bit of a bedrock for this, because the INT is a bit of an NHS construct. And it's all about complexity and it's about stopping people going into hospital. And if we're not careful, we're going to forget about all the great work we did in local design teams. And actually, all of that work is ultimately going to stop people going in hospital as well. So it's a real interesting thing is that there's an NHS requirement to set up INTs, but we couldn't do that without the work that we started a few years ago around integrated neighbourhood working. The same with some of the things that the public health are funding, the investing in communities, the thriving work, all of that is the bedrock of being able to deliver integrated neighbourhood working as a concept. Forget about what we call it in the NHS.
So they carry on then?
Well, I think this is what's an interesting point because my team were doing a lot of the management of that and I have had to redirect my team into making this happen. So we have had to rely on community leaders and community teams. And in Cotgrave, it's brilliant. It's working really, there's a lady there who's really pushing forward on some long-term conditions working groups over there. So where we've got community groups who've come together and are supporting that, it's working really well. So it's not, you know, underpinned by some of the NHS resource. But again, it's within the voluntary sector, it's a challenging environment.
Okay, I've got a question from Councillor Adegoke, but I'll just advise members that we do have another item to discuss, so I'm probably going to wrap things up after Councillor Adegoke, and then we'll move on to the next agenda item, unless there are any other burning questions. So I'll pass to you, Councillor Adegoke.
Oh, yes. Sorry, it's not going to, I won't take a lot of time. You've spoken very well about discharge and all of that, and following on from Councillor Butler's submission as well. I just wanted to draw your mind back to how do you improve discharge planning for patients who are elderly, you know, and those who need multidisciplinary support, you know, so that when they get home, they have continuity of care, you know. I think you've not really spoken about that, or you've spoken really, but generally, you know, but I wanted to address, you know, this particular group of people, the elderly people who are frail and would be in this category of people who would need extra care, you know, and so we need to hear about your planning improvements for them. What is in place for such people who need extra care, extra support, you know, to get going after you discharge them?
So shall I start? So within the hospital, when we are planning discharges, you're right, it is our older, frailer population that will need to go out on those supported pathways. So it might be a care home, it might be a nursing residential home, it might be palliative care. And those are the patients that need more planning, more communication, and that integration into where they're going next. So we have to make sure, and in the report it talks about the discharge plan. So the discharge plan is very unique to that individual, and it will touch on everything from their medical needs to their social needs and where they're going next, because that's a really important point. So it might be that somebody, a frail elderly person, leaves hospital and actually what they need is a period of rehabilitation. So it might be walking and mobility, and it might be that they go there for 4 weeks, and then it might be that they then step down from there and they go home with some support with things like washing and dressing. But that discharge plan is absolutely based on those individual needs, where they need to go to make sure we give them the best possible chance of going home and being as fit as they can possibly be. But it's absolutely on those supported pathways. So rehabilitation, home with support, nursing homes or palliative care that are mostly our frail older population that go every day. So they are the people who are more complex to leave, and we spend more time planning and talking and working across agencies to make sure that we get them to the right place based on their needs.
Oh, brilliant. Thank you. Thank you very much.
Do any members have any other burning questions? Right, Lloyd. Just a quick one from me. First of all, thank you to all the members. I thought there were some great points and questions brought out there, and thank you to yourself, Gemma and Fiona. I thought there was some really good answers as well. So yes, thank you very much. Just one from me, and I'm very simplistic because I'm northern, so you know, I do apologise on that. But these INTs look very much like just common sense. It's common sense, and it's getting people from different teams within an organisation and different organisations talking so that we can actually identify the best outcomes for patients. I hope that sort of summarises it quite well. So for me, the question I've got to ask is there sort of a freedom to the teams to go out and find solutions, think outside the box. And I think of the National Rehabilitation Centre and how they've designed that whole centre of thinking outside the box and getting patients moving in different ways and being more holistic. So do these integrated neighbourhood teams have the freedom to go and find different solutions that aren't just, you know, an in the box solution? Or do we get quite a lot of computer says no when teams want to be quite innovative? And the reason I ask that is I went to the GP. I'm not a regular attender at GPs, but the last time I went was for a throat issue, and there was a concern I might have throat cancer, but the nurse practitioner couldn't refer me because I didn't tick all the boxes. So is there a box ticking part to this and a computer says no, or are we going to let these INTs be innovative and find solutions that really do help the patients and get them, you know, sort of discharged and back to a healthy lifestyle?
Thank you, and I can beat you on the northerliness, so don't talk to me about the north. Yeah, so I mean, it's a great question, and I think that's why staff say to us, well, this is what we should be doing. This is why I joined the NHS or social care, because I wanted to do the right thing. And sometimes, and I think from a commissioning perspective, we haven't necessarily set things up. We've set a contract because the money's really tight. The provider works to that contract, and no, you can't step outside the box, or you can't step outside the box because there's regulation. So we absolutely need to create that environment, and that's what we're trying to do within the INTs, to say what is the art of the possibility. Now we're in this room talking together, and how do we do that? And that is still massively challenging, because some of our, particularly our community services providers, have got a lot of things to be doing, and they can't afford any patient safety issues, and so are really tight around what they do. So we absolutely have to create that environment. And I think a couple of things that are going to come in this year, the government are talking about neighbourhood contracts. They're going to talk about multi-neighbourhood contracts, and that will be about us as an ICB indicating our commissioning intention. So what is it that we want to see? What's the impact that we want to see? And how can providers come together to deliver that? So the environment should be a lot better for that. Having said that, it'll be an immense challenge. We'll have people who will only want to work in that box and don't want to leave that box, but we've got lots of people who recognise the collaboration and how that needs to work together, and we need to work together to make sure people have that environment to work in going forwards.
No, thank you very much for that. And I think the sentiment from the committee is very much that this is quite an exciting move, you know, and that these teams, we can see the value in it. So hopefully it does carry on that trajectory, and you know, there is that allowance for innovation and doing things differently. It's great. So there's nothing much more from me. I know INTs are very much in their infancy in terms of being brought to life and developing what they do. So I would at some point like to invite you back to see how progress is going on that, when you've probably got a bit more in terms of data for, you know, outcomes and things like that. So I will thank you for your contribution this morning, and I will now move on to our recommendations, which is that the report be noted. The report be noted? Yeah. Thank you. And that feedback of members on the impact of integrated neighbourhood teams be noted. Thank you very much. Lovely. Okay, so we'll move on to the next agenda item, which is one I'm looking forward to, which is about men's mental health provision and prevention. So we're now moving on to agenda item 5, which is about men's mental health provision and prevention. Members are asked to take a broad look at the overall service provision and what is being done to help promote resilience before specialised services are needed. This item is not focused on, but does touch on the topic of suicide prevention, which is a delicate issue. For that reason, I expect everyone to maintain a tone of respect during proceedings. A full discussion of suicide prevention will take place at the Overview Committee on the 7th of May 2026, and this item today will not duplicate that discussion. If members want to feed into a discussion on suicide prevention, we can arrange this separately. Thank you. The report is from the Nottinghamshire Healthcare NHS Foundation Trust in partnership with the ICB and Public Health in respect to the support for men's mental health and prevention work that is currently available in Nottinghamshire. We are just awaiting some of our presenters. So has Louise gone to fetch them? Okay, so I shan't be premature in introducing them. I'll wait until they come.
Thank you very much. Bye-bye.
No, there is one six and one eight. It's good. Big thing for me when
Well, yeah.
What about three committees here?
Just wait for Rebecca.
Yeah, thank you. Thanks very much.
Sorted.
Are we using the mics or not?
We are, yes, yeah. Okay, good morning. Thank you for attending. I've just started introducing the topic of this agenda item, which is a focus on men's mental health. So just to welcome our presenters. So we've got Jan Senzia. Did I pronounce that correctly, Jan? Jan Senzia?
That's it.
Yeah, sorry. And you're the NHFT Executive Director of Partnerships and Strategy. We also have Jenna Davies, licensed mental health technician, and Rebecca Keating, who's the clinical director for NHFT. And they're also joined by county council colleagues, Viv Robbins, who's the director for public health and communities, and Louise Lester, who's a consultant in public health. So welcome to you all, and thank you for coming. Jan, could I turn to you to introduce the report, please?
Thank you very much, Chair. So thank you for inviting us today and for your very insightful questions that you wanted us to address in terms of men's mental health. I think it was first off we wanted to really emphasise the fact that we absolutely understand that for the Trust, our services are only part of the system in terms of helping support men's mental health. It is a complex issue and it does require system support. So we, generally speaking, as a Trust, are responsible for what's called secondary services, and therefore in the most part we're dealing with people with severe mental illness. There are other services, you'll have heard of NHS Talking Therapies. We don't deliver that in the Trust. That's commissioned by the ICB. And there also are a whole range of offices, primary care, and then there's a whole range of other support services. And I'm really pleased that Viv and Louise were able to join us today because they have that knowledge of that wider overall prevention system. But we do have a very important role to play in the Trust in supporting men's mental health, particularly at that severe end. And we're talking about conditions such as schizophrenia, psychosis and bipolar. But we also do have some prevention services, and I know you were interested in talking about the mental health in schools, which is one of those, and we can come on to that in more detail. I know Rebecca can give you more detail about that. And we do have some non-medical services that we do to support, particularly, I guess I'd call it secondary prevention. So it's really to help when we're discharging patients or when patients are moving through the journey of recovery. We have some services that will help them there, and I can talk a bit more about that in a moment. So the next slide, I think, the slides on there, lovely, thank you. Just gives you the numbers in terms of the number of people that are in our services. So in our report, we gave you a little bit more detail about some of the access issues, but in here we're just talking about the actual volumes. And you were particularly interested in that gender breakdown. So this gives you an idea. I think it's interesting to see that in general terms, we have more males than females in our inpatient services, in our assertive outreach pathway, and yet in general terms, again, we have more females than men slightly in our local mental health teams and in our personality disorder services. So that's just to give you an idea about that gender breakdown across our different services. And then in terms of access, I know you would have seen from the paper that we sent in that there is a discrepancy between our local mental health teams in terms of the waiting times for assessment. And I know Jenna can talk more about that, but some of the key issues there are down to our staffing, are down to sickness and other factors that have come in, but that we want to talk to you more about what we're doing both to keep people well while they're waiting, but also in terms of how we're addressing those issues and trying to improve performance overall. So I won't dwell on that now, we can come to that when we come to your questions. So in terms of prevention and recovery, I've mentioned the mental health support team in schools. We're now pleased to say that we've got over 50% of the schools in the county are covered with mental health teams, and we have a clear plan to get that to 100% by 2030. And as I say, Rebecca can talk far more about that, has some expertise in the children's pathway and what we're doing there, but it is something that is being supported by the government, and it's come quite strongly through in the 10-year plan and in recent planning guidance. We also have a number of other services around the MBT service, the drug and alcohol, particularly of note, perhaps the Recovery College. I don't know how many members are aware about the Recovery College, but this is run very much on education lines. So our students, we don't call them patients when they're in the recovery college will attend a series of classes. They could be on a number of different issues. It might be anger management, it might be, we have specialist courses on autism, living well with autism and living well with ADHD, for example. And it is run very much, it has a prospectus, it has a brochure of services, and students can pick, I think it's up to 3 courses per term. It runs on academic years, and it's subject to Ofsted rather than CQC regulation. And we do that in conjunction with Nottingham College. So that's quite a different type of approach, not a medicalised approach. And similarly, we, alongside and embedded into our local mental health teams, we have the Futures Positive, which is the individual placement and support service. This is a very, I think it's an incredibly good service. It's a very intense service where people are supported both to get into work, but also we support people to stay in their jobs, and we support people after they've started a new job to help keep them in those jobs. I've had the privilege of sitting alongside Future Positives workers. I've sat in on interviews. The one that I can remember was very much preparing somebody for a new job that they were starting and talking through all the things that might cause them anxiety, that might cause them difficulty, and coming up with strategies to help them deal with that. And also about how to ask employers for any reasonable adjustments that they might need to have made to help make sure that they can be successful in those jobs. It's a very, very good service. And I'm very pleased again to say that that's something that's been recognised nationally, and there is more funding going into that, and we're expecting that service to expand next year. And then we have outreach clinics as well, particularly dealing with severe multiple disadvantage. I know that members were particularly interested in how we get feedback from our patients and service users, and also what we do with it. And we can talk in general terms about some of the processes that we have in terms of, and Jenna can give you some examples of how, as a matron, we're dealing with that on a daily basis. Just a couple of examples we've given in here. We got a suggestion here, and some really good feedback about that Future Positive service. And people saying they wish it was more widely known. So I suppose the UDID is we are working hard to make it more widely known. I know Jenna and other teams across the county are ensuring that there's a really clear referral to Futures Positive for their patients, and making sure that even when patients haven't asked for it, it hasn't been indicated, it's something that's thought about in terms of recovery and how people can go forward. But also we've got that expansion coming, which is really good news, and that can go forward. And then the other quote is one around which we do hear frequently, was about waiting times. And we know that our waiting times are not good enough, like many health services, both in physical and mental health, we are struggling to manage demand, and we are struggling to manage the numbers of people that need assessment and that need treatment. And we do have that inequity across our county, which you would have seen from the report in terms of different teams, which, as I say, we can talk more about, but we know that in particular teams, we've had some really high levels of sickness. We've had some difficulties filling posts, and that has caused big difficulties. We do have plans to work on that. And again, Jenna can talk more about that once we get into the questions. So I will leave it there, but I know that Louise, you've got the slides. If you want to just cover that off before we finish the presentation. Sorry, you just need to move on to the last slide, please. Sorry.
Next one.
That's it.
So yeah, in recognition that we know sort of mental health and well-being takes everyone in the system, and everyone's got a role to play in that. Just highlighting a couple of the areas that are detailed in the report, where we provide support in terms of that mental health promotion, so strategies, interventions, and campaigns to support both individuals and communities, and that includes in some of those specific work working with males and young males as well. So We've got the Not Alone website, which is an all-age website, so separate sections for children and adults. Hopefully colleagues are aware of it. It's award-winning, and that provides advice and information to help people ensure they're getting the kind of right support at the right time. And alongside of that is also a comprehensive comms campaign, things like podcasts, Not Alone live events and public events working as well. We've also got a number of system-wide strategies that include aspects of mental health and wellbeing. So right from that real early intervention prevention when we're thinking of best start in life. So looking at particularly parent and infant mental health, and there's specific work streams around kind of Think Dad within that, and make sure that that fathers and kind of male carers and grandparents are included in that. We've also got a self-harm and suicide prevention strategy that again is system-wide, looking at how we can reduce self-harm and prevent suicide. We know that males are a particular target group for some of that work, so some of the comms campaigns that we're doing are specifically focused on males and working to be co-produced with our communities and our population. We also run a mental health wellbeing small grants programme, so that was across City, County and ICB when it first started, and through that we've been able to award small grants to a number of kind of community and voluntary organisations across the county who are supporting things around mental health and suicide prevention, and a number of those projects have included areas that are specifically targeted at males. And then again, in terms of our community provision, we've got 26 libraries now, part of the National Places of Welcome initiative, so where people can go and have a cup of tea or a coffee and a chat, and hopefully reduce some of their isolation and kind of loneliness, which again we know are some of the risk factors for kind of mental health and wellbeing. So that's just a snapshot really. There's lots of activity going on across the system from a early intervention and prevention approach.
Thank you very much for the introduction. So I will now open up for the debate. Councillor Rich, do you want to lead?
Okay. Well, look at the data. It looks like a postcode lottery, if you ask me. So waiting times at basketball is about 10 weeks. Whereas Broxton and Huntnall men are waiting 18 weeks, so it depends on geographic areas. Bob's question is when are you going to rectify this issue in itself? Thank you.
Yes, just push that one. Thank you. We've got various plans in place and absolutely recognise that the wait for assessment and for treatment is a problem. It's not just the wait for assessment, it's once a person's had their assessment, there's a wait for specialist treatment is too long. Broxton and Gedling and Mansfield in particular are problematic. We've got a developing plan in place to have an overarching solution. So we've been to visit a couple of other trusts who've reversed the problem in their own areas and gone. I think Oxford went down to about an 8-week average wait, which is much closer to the ambition. But we're not convinced that their model is going to suit our population. So we are trying to do a bit to make that work for us. In the meantime, though, we're also trying to work with what we've got. We started with Gedling because they were in a particularly difficult situation, and we're doing caseload reviews of every patient who has a care coordinator to make sure that we're care coordinating the right people and that we've got a plan to work towards at least discharge from care coordination to stay in the system, maybe in a different way or maybe with a plan for other providers and the wider community services. If we can create some flow with with patients that are already in the team, then we can allocate more time to assessments, because not everybody that we assess comes into service. And actually that's a particularly troublesome time for people if they've been waiting for a long time to get an assessment to then be told we're probably not the best people to help you. That's disappointment after a long wait, isn't it? We've done some looking at the data to see where we're losing appointments. So in the waits for assessment, if the longer they get, the more difficult it is to have people attend their initial appointment. So we're trying to add in systems for reminders before appointments. Longer term, we hope to have we're running through a couple of different models to be able to look at the front end and assessment and possibly some short-term treatments attached to that. But in the meantime, we're not taking our eye off the ball, and we're trying to make the best of what we've got and utilise the resource that we've got properly, make sure that we're doing what we should be doing when we're doing it.
If I can just add to that, I think it's fair to say that we're doing a lot of work on how we manage our sickness absence. We're also doing a lot of work on ensuring those teams are properly staffed. And Jenna was telling me that we have got some additional resources coming into those teams that are most challenged in order to try and achieve that. The other thing that Jenna, I know you were telling me is that that work that's been done to analyse the people who don't attend appointments, and we all know in healthcare, non-attendance of appointments is an issue, has thrown up some very fascinating facts, particularly around patterns of non-attendance. I don't know if you want to say more about that,
Yeah,
Jenna.
absolutely. So we've looked at various things, even weather and how that affects attending appointments, whether medics or nurses are offering the initial assessments, whether that's got an impact on uptake. And there are some funny little idiosyncrasies and little quirks to each area. So in Rushcliffe, men from a higher socioeconomic background don't come on Tuesday mornings, and that is kind of borne out over months and months and months of data. So we're not offering men assessments, but when we're allocating those appointments, we're trying to think differently about where we offer them, and not booking appointments for 9 o'clock in the morning because they're really poorly attended. So shifting our working day around to make sure that kind of what we're offering fits with what the data tells us. In terms of sickness and absence management, from spring till summer last year, and only really with some initial recovery coming in autumn, we had a huge proportion of staff off on long-term sick. We are being more assertive of how we manage that, and we have got processes in the trust, and I'm not sure that we've always followed them as assertively as we should do. So we've got a greater appetite for performance management, we've got a greater appetite for sickness management, and actually having that culture is getting people back to work, people feeling like they understand the boundaries and that they understand the obligation has helped. We are also looking at the amount of initial assessments that each clinician can offer during the week, and there have been historical agreements with some of the disciplines that work in mental health teams that they don't conduct initial assessments, and we're trying to change that to bring a little bit more assessment capacity into the system while we wait for the bigger changes in our plans to come to fruition.
Thank you. Councillor Barlow.
Thank you, Chairman. Thank you. That's a very good report. Thank you. Can I just ask? So obviously, looking at the areas that you are looking at into men's mental health, unless I missed it in the report, there was no mention of the farming community. Obviously, because the area I cover is quite rural, there is a huge farming community, which leads me on to my second question, which is obviously you've got 3 crisis sanctuaries, the Mansfield works up in Chimwell. There's nothing in the Newark or Rushcliffe area. Is there any plans to have crisis sanctuaries in that area?
I'll start. So I'm not going to be able to comment on the farming community in particular. I don't know if any of my colleagues can, but we can take that away if not. Clearly, obviously, our services are open to all, but I don't have any specific information on the farming community. We can take that away. In terms of the crisis sanctuaries, so one of the things that's again set out in the 10-year plan by the government is the creation of 24/7 neighbourhood centres for mental health. And one of the things that we've been looking at in with our colleagues from the ICB is how that's taken out into the county and into the city as well. We don't yet know exactly what the funding mechanism is going to be. We don't yet know how the plans are going to work. But I think what we do need to do is to think about where have we got crisis sanctuaries, where have we got 24/7 neighbourhood when they come on stream, and making sure that we've got that geographical coverage. So at the moment, there are no plans to have a crisis sanctuary in Newark, as far as I'm aware, but that is something that we're absolutely looking at, that geographical coverage across the patch and making sure that we have got some kind of support in as many parts of the county as we can. Clearly, with a large county as we're dealing with in Nottinghamshire, with, like you say, they've got a lot of rurality, we're not going to be able to cover everywhere, but we need to make sure we've got those real central hubs, and Newark is clearly one of those hubs, so we need to be looking at that. I don't know if Rebecca wants to add anything to that.
Yeah, so one of the other things that we're doing is working closely with the ICB on a crisis improvement group, looking at where some of the gaps might be and where some of the opportunities for further development are. And some of that is looking at working with our voluntary and community sector colleagues. And so there are discussions ongoing about what that might look like in terms of kind of crisis drop-ins and crisis sanctuaries that are supported with VCC colleagues as well.
Thank you. Can I just ask, is there any plans to sort of extend the hours? I notice obviously they've got limited hours at the moment. Is there plans to extend those?
I think that fits in with what we were talking about, the 24/7 neighbourhood, and that is quite a revolutionary kind of idea, which, as I say, it's very much in its infancy. We know it's the government ambition. We're waiting to find out more guidance on how we implement that, but we are working with our ICB colleagues on that.
So I was just going to pick up the question on farming communities. So we know that our farming communities have particular challenges that other communities may not have. And Louise can come in a bit quite fine in terms of some of the specifics. But even if we just think of the rurality, the complexity of the role, the long periods of time working potentially on their own, we know that there's higher prevalence of things like loneliness and some lower level mental health illness in some of our farming communities. So I think it really comes back to the equity angle that we talk about a lot in terms of how do we flex the services to meet the needs of those different groups, and which I'm very happy to help and support in terms of some of your course development work, because I think we have to acknowledge that we're not going to be able to have hubs and services in every single location, but that doesn't mean that we can't reach people in different ways. So Louise has articulated around really good resource around Not Alone. That's an online resource that will work for some, that won't work for others. But I think there's something about really understanding those different population group needs. Farming communities is one, severe multiple disadvantages is another, and lots of different groups, so that we really are having that equitable approach. Louise, I don't know if you want to have anything.
Thanks. Yeah, just in terms of the specifics, so the communications campaign that I talked about, where we're going to do some targeted work in males, the farming community is going to be one of those kind of target groups, and we're looking at launching that at some point this year. And our district and borough colleagues have already indicated their supporters with the kind of distribution of that. So yes, recognise it as a risk factor for kind of poor mental health and also suicide. Doing some targeted work, and like Viv says, all the other work that we're doing because of the multiple factors that are involved in mental health and well-being, hopefully will support that as well.
Thank you. Can I just ask on that, what you said about the targeted approach? Have you actually worked with the NFU on that?
I can't tell you for definite, but I will. I'll make sure colleagues are linked in. Thank you.
Councillor Stoll.
Oh, thank you, Chairman. First of all, thank you for the work that you do. It's a very, very complex area, and to prevent suicide, you need to obviously understand the causes of suicide, and we could talk for weeks on that. That goes very deep, but it's more of an observation, really. You already touched on pressures of the system. Councillor Rich mentioned about waiting lists, so it doesn't seem very scalable, and I can see a point very soon in wider society that we're going to see an explosion in mental health and suicide, particularly with the introduction of AI, and I'm seeing that in my own industry with the amount of jobs being lost. So I can see within the next 12 to 24 months that we're going to run into some serious societal problems. You've already mentioned, obviously, about the waiting lists and the scalability. So it's not really a question; it's just more of an observation. But where ultimately can this service go, and how would we even look to address anything like what I think is probably becoming our way? And this is a national issue, internationally.
I think you're right. I think it is international, and I think it's something that I guess it takes a whole society to really look at those issues and think about how we address them. Specifically, in terms of our capacity, I think Jenna has outlined that we think there is more that we can do in terms of our own productivity to improve the situation, and that's what we are really working on. We think there is more we can do in terms of our models of care. I think over the years sometimes different things develop, and therefore you end up actually having quite a fragmented system. And I think the developments we're doing internally, and then also the work that we're doing with partners such as the County Council, but also ICB colleagues and other colleagues, and the voluntary sector really crucially, and the development in terms of, which I don't think we're anywhere near yet, but the development of integrated neighbourhood teams, I think will also help because we can start thinking about communities. But I also know Rebecca's spent a lot of time working in our children's services and is well aware of some of those modern societal pressures and how they're affecting young people. So I don't know if you wanted to say anything, Rebecca, on that.
Yeah, so within the mental health support teams in schools, some of the areas that they pick up are young people's concerns about the influence of social media, the influence of digital, and the influence of AI. And so they do offer workshops to young people in how to kind of safely navigate those areas. I think what we also are doing a lot more of currently is what we see in CAMS is also, or child and adolescent mental health services, is also what we tend to then see coming into our adult mental health services, and presentations do change over time. So we are working quite closely with both services to look at making sure that we're prepared for those changing presentations that are going to be coming through into our adult services, so that we're ready with the interventions needed and we're not kind of on the back foot with things. So it doesn't necessarily answer the wider societal issue, but we are trying to work with our young people to help prepare them for some of that as well.
So I think in local mental health teams, in adult mental health teams right now, we are feeling quite a different flavour of difficulty coming through to us. A lot more focus on neurodiversity, a lot more experience of dissociative type presentation, complex emotional needs that in young people that maybe we didn't see before. We have to learn to flex with that, and the understanding of mental health and mental ill health and how that should be addressed is changing very broadly over time. I wanted not to mention COVID, but I think it might be inevitable, and that's had a significant impact on certain tranches of young people. They were at different stage of social and educational development when that interruption happens. So each stage of their next stages, they're presenting with slightly different experiences and needs. So we've got to be nimble. We've got to understand people as they're coming through. I think there's always room for improvement in how we deliver services, what our pathways look like, who we accept into service and who we don't. But there's a broader understanding, I think, of how the world is changing. It's a difficult world to live in for a lot of people right now, isn't it? Financially, geopolitically, we've got more people presenting with really acute social problems and poverty-related distress. We've got to adapt.
Can I build on that, if I may? So you would expect me to say that prevention is always better than cure. I think building on something that Louisa's touched on before, we're doing a lot of work from a public health point of view. You heard me talk around the building blocks of health earlier, around how those broader social determinants of health wrap around us and create the environment that lets us work, born and grow and live. Now that has a really significant impact on our physical and our mental health. And I think some of the work that we're really doing is one, understanding that complexity, but really thinking around how do we support our children of today to be strong and thriving adults tomorrow. So we talked a little bit about the thriving communities approach in terms of how do we develop more of that thriving and resilient community, so there's more community cohesion. There's more resilience within those communities to support each other and help themselves. We do a lot of work around linking to the Best Start strategy, which is really thinking around how we know that those 1,001 days from preconception to the age of 2 are absolutely crucial in any child's neurological development. And what can we do to support those families to ensure that those children thrive? Because some of the seeds that are sown in those first 2 years will then go on to produce lifelong difficulties for some of those individuals. Some of that might be around some of the work we're doing around, trauma-informed work. So we know that, for example, children that live in a household of domestic abuse might have some considerations and some more barriers that they might need to work through as they move forward. So I suppose for me, it's something around really thinking around that broader approach around how do we particularly work around our children, but also make sure that we're putting in the preventative and early help options in at a very early stage, so that if individuals are struggling, that they're getting the support early doors rather than needing to go and access your services until later on. That's broader pieces of work and certainly something that we're trying to develop even further.
Yeah. Thank you. Councillor Butler.
Yes, thank you, Mr. Chairman. It's so important, so complex, isn't it? The whole arena of mental health, and it's a big challenge. It's good. I mean, perhaps one of the challenges is we're in a good position. The more and more people are talking about it, and there's more acceptance. I mean, I remember 20 or 30 years ago, someone was having an adult in particular was struggling with something. They either wouldn't know it themselves, or even if they did, they wouldn't talk about it, and they'd go off sick from work, citing other reasons for going off sick, colds, flu, or whatever. When in actual fact, there's something going on, and it's good that people are accepting that now. But sometimes I wonder whether the high numbers of cases you're having to deal with is because there is such a spike in people having a problem crisis, or the fact that more people are recognising that they're having that. And I'm sure there's lots of studies going on as to the background. But my main query is about the school side of things. You've said so far 50% of schools are engaged so far, and you're hoping to get them all by 2030, which is what, another 4 years or so away, isn't it? How have you found the response from schools? So how are you choosing where to go to in the first tranche, in the first set of schools you're going to? And are you getting, dare I say, and I don't wish this is criticism for anyone, but are you getting resistance from schools perhaps who might consider their people haven't got a problem, or they've got, and I'm not being disrespectful here, they've got so many other things to be doing that have they got time and resources for doing this? How are you managing that side of things? And then just something, picking up on something that you mentioned in your presentation, you referred to a recovery college. Is that literally a physical place? I don't know where it is. And, I mean, you mentioned New College, but maybe a bit more information about that.
I'll just cover that last one very quickly and then hand over to Rebecca to talk about mental health in schools. So the Recovery College is a physical place. It's based at Duncan Macmillan House in Mapley, which is where the Trust headquarters used to be. Yeah. We have tried in the past outreach across the county. It hasn't always been as successful as we would have liked. You'll all be aware that Duncan Macmillan House is up for sale at the moment. The Trust has made that decision in terms of moving out of that building. And so we are actively considering what the future and whether we should actually redouble our efforts to try and make sure that the Recovery College is accessible to everybody across the county. People do like a physical space, and people do like to have a space, because we tried hiring rooms across the county, but what the Recovery College offers is also that drop-in space, so the people who are attending the college, actually it's the peer support that they get a lot out of. So what we need to do is make sure that wherever physically we take it, we've got that ability to have that peer support, because that's a very crucial part of it. And of course we're looking at digital and online options, but I think having been visited and spoken to some of the students that are going through that physical contact with people, that human contact, if you like, has been so important to people. So we need to make sure that we've got that accessibility. So we're working on what our strategy is going to be going forward. Thank you. I'll let Rebecca
just before you get
sorry.
How do people know about it, and how do they get to it? Do they refer themselves, or do they have to be referred?
By and large, they're referred from their local mental health team. So it will be part of, as Jenna's teams are thinking about discharge for a patient, then it will be one of the things that can be offered to that patient. But I mentioned the learning to live well with autism and ADHD, and I think Jenna and Rebecca have talked about the increased presentation of people with neurodivergence. And so one of the things that we're doing, because we also have very, very long waits for assessment in autism and ADHD, and one of the things that we're doing is offering people who are waiting for assessment the ability to go on those courses, because they're useful, whether or not, even if you end up with not getting a formal diagnosis of autism or ADHD, the techniques and the strategies and the peer support are useful to people, so they can benefit from that, as well as through that referral through the LMHTs. Shall I hand over to Rebecca now on schools?
So with the schools, initially it was slightly mixed. Ashfield were the first school nationally, Ashfield Comprehensive were the first kind of rollout nationally, and had some really positive feedback. And I think because the MHSTs have been rolled out over a number of years now, the success of them has then kind of been shared with the other schools. So we're finding now that whereas we were knocking on their door to start with, they're actually now, we are getting some schools approaching to say, we'd be really keen to be involved. So that has definitely been a real positive. One of the difficulties is that in order to progress to put an MHST into a school or to involve a school, they do need to nominate somebody to be a mental health champion. And that's often going to people who might already be a champion for safeguarding, a champion for special educational needs. And so that part is another duty on top of people's already very full days. But as part of the offer, we also offer support around kind of teaching staff wellbeing. And so that does tend to kind of mitigate, because we know if our teaching staff are mentally well, that supports the mental health of our young people as well. So I think it's the success of the MHSTs that's making it slightly easier to kind of roll out further. In terms of any threats, so the MHSTs are kind of nationally mandated and being nationally rolled out.
We only tend to hear a couple of months before the start time whether we're going to have additional waves allocated to our area. So the timescales to then be able to recruit people into post and get people onto the right courses can be quite short. So we have found that challenging, but we have always managed to do so. Within the MHSTs, one of the roles is educational mental health practitioners, and they do a year's training as part of the rollout. And one of the things that we've seen is that we've trained quite a few people up, and then they've used that as a bit of a springboard to then go on to either do the CBT training to kind of progress, or to kind of pursue a different career progression point. And so we are being able to use what the universities are calling attrition places to then, even if we've kind of developed an MHST and kind of got all of the skills, if we then lose people, we're able to bring people in and get them trained up to refill those places. So we have managed to find ways of kind of managing some of those difficulties and barriers. We've also managed to get a project manager in post, because one of the difficulties historically is when a team is commissioned, you've got to recruit the whole team, including the team leads, and you often need your team leads to be then doing the recruitment for everybody else, which can, the timings don't line up. So we've been able to recruit a project manager who can then support the oversight and make sure that everything does line up and falls into place, because a lot of the recruitment is joint with the universities to make sure that people are able to get onto the courses and have the qualifications to access the further education in either the educational mental health practitioner course or the CBT practitioner course, and to have adequate supervision over those.
Can I just
Of course, yeah.
Thank you. So in terms of the progression of the mental health support teams, as Rebecca said, obviously we were the first in the country to launch, and it was over a number of waves. That initial decision about where they were was taken in partnership with health colleagues, education and social care, and they also used data to make sure it was targeted, and that included deprivation, number of children and young people eligible for preschool meals, number of children or young people on child protection plans, safeguarding assessments, children in care, that those kind of factors were considered. And we're really fortunate actually in Nottinghamshire that we had quite a lot of mental health support teams set up compared to other areas in the country. So now if we think about the national target to make sure everyone has one, that obviously has to be phased across the country. And if we're already at the higher end, unfortunately that means some of our progress might not be as quick as other areas, but that's because they haven't got as many as us at the moment. In terms of some of the detail of mental health support teams, we've had a really positive external evaluation by Nottingham Trent University, who have looked at the model in this kind of city and county and given some really good feedback of both what's working, but also improvements that can be made, and that's available. Mental health support teams are commissioned by the ICB, and ICB and healthcare colleagues came back in, I think it was 24, to Health Scrutiny to talk about the work that had been done. So I wonder if it would be useful to circulate that report, because that gives a lot of that background of kind of why they started. In terms of, I suppose, one of the risks is, okay, well, what if you're a school that doesn't have a mental health support team? What's going on there? So again, within the Healthcare Trust, they provide the 0 to 19 service, so your health visiting and school nursing, what you might be familiar with. And that team also do a lot of great work in schools, so there'll be some support mechanisms there. And there's also other services that the RCB commission, so BU NOTS, so there is support in place if you're a school that doesn't have a mental health support team. And we have a really good system group and system strategy for children and young people's mental health, where all of the partners come together to talk about exactly those kinds of things, and make sure we're doing everything we can to support children with both early intervention and prevention, but also making sure they get the right care at the right time. Back to what Liz point said about children being the adults of the future.
Thank you. Councillor Odegoke.
Oh yes, thank you very much, Chair, for giving me the chance to say one or two things. Yeah, thank you, Councillor Adams. I think Rebecca has actually answered most of the questions I wanted to ask. You know, it's based on what Councillor Jody had also talked about. I was just going to ask about how the system that is in place, to strengthen intervention pathways for the younger ones, the boys and the young men, in schools, and things like that, so that we can prevent them going further into crisis, and I think you've talked about it quite well. You've talked about the AI as well, and so that's good. But if you also want to say one or two things just to add to that, that would be good as well. Thank you.
Thank you. Yes, I think within the mental health support teams, it is built on kind of a cognitive behavioural therapy model. So the interventions offered are very much evidence-based, and the emotional education support workers are also kind of trained in what they term as CBT Light. So although they won't be offering full CBT, the interventions that they offer will be CBT informed. And a lot of those do look at kind of well-being and living well, managing anxiety. And quite a lot of those are done either individually or in group format. And the feedback is, particularly with the group formats, that although young people can be slightly hesitant about attending a group, actually the recognition that a lot of their peers are experiencing the same difficulty can be quite validating, and it can help them feel as though they're not alone with their difficulties. In terms of kind of slightly more broader, within our cancer services, we have a number of different care pathways. So we would look at what are the needs of somebody coming into the service. Is it that they are struggling with anxiety or depression or obsessive compulsive disorder or psychosis? And then we've designed care pathways in line with NICE guidance and evidence to say what interventions we're going to offer to them. And it works on the Thrive model, which is kind of initiated by the Anna Fraud Centre in London. And it looks at that graduated approach. So the first is that a young person would be thriving and wouldn't necessarily need the support. Then there's kind of getting help, getting more help, getting risk support. And so within the pathways, we're able to take all of those considerations into account to look at where somebody comes in and their needs might be lower. We'll offer the intervention that's more targeted, that would be briefer, but be able to meet their needs. And then if somebody comes in with more severe difficulties, we would then look at kind of scaffolding that intervention to meet that more significant need. So I hope that answers your question about how we...
Yes, it is. Thank you
that works.
very much. Thank you.
Do you want to just add, we haven't got colleagues here today from our children and families team in the county council, but obviously there's a large amount of work that they do to support young people and including that young boys and males. So that includes the work of our family hubs, which are obviously kind of 0 to 19 and across the county, and family hubs network, which include healthcare trusts as kind of key delivery partners as well in that. We've also got the youth service and the fabulous work that they do, and a newer work stream around kind of adolescence and thinking of that as kind of a critical time period for lots of things that include in that mental health and wellbeing as well. So there is lots of other work in the system that is that's going on. That's just a couple of examples.
Thank you. Thank you.
Councillor Dodds. Thank you, Chair. I've been involved with, or been around more involved with mental health support over the last few years. I had a friend called Sam, a school teacher from Worksop, tragically took his own life on the other side of the world. But I often think out of the darkness comes light, and the light in this case was his parents and his best friend set up a men's support group called In Sam's Name, as I think some of you might know quite well. The group's gone from strength to strength. It's a voluntary group, and the moral of the group, or the motto, sorry, is a brew and a chat, we've got your back. something as simple as that. It's not a saying that's been created by healthcare professionals. It's just people who are folk who care and want to do something for the community. So perhaps this doesn't happen to somebody else doesn't lose a son. But what's become apparent to me as I've got involved with it, I donate money to them out of my divisional fund to help support them. I go to the meetings, I'll be there Thursday night to offer my support or help in any form I can. But we have a meeting group now in Worksop, one in Retford, one in Ollerton, Sutton in Ashfield, Kirkby in Ashfield, I think there's one somewhere else. There's now an In Sam's name group for her, which I think is just in the Worksop Centre at the moment. It seems to me that we've become very over-reliant on the voluntary sector to offer men's mental health support. And I'm interested that the mention of sickness and difficulty filling roles has cropped up a number of times here today. I've recently saw a staff engagement survey around Nottinghamshire healthcare providers or professionals or management, which came back with some very low scores from the people who were surveyed, i.e. the people I'm guessing who are on sick, don't feel supported. 50% of the people don't feel supported who are working in Notts County Council or mental health support. I'm just wondering, is there an issue here how you've started to performance manage, Jenna, as you mentioned, and this is causing this issue? Or have we got a wider management culture issue here that's stopping these people from getting to work and filling these roles?
Performance management and sickness management isn't meant to be punitive. It is. I think we've had some. I'm very new to this kind of leadership position in healthcare. I was a face-to-face, still seeing patients in the middle of last year. So I suppose I know what it's like to have been managed and led within the organisation, and then to see kind of from this new perspective what that looks like. I think it would be easy to perceive that performance management and sickness management is a punishment or is punitive. But actually, us adhering to those policies means that we keep in touch with people who are off sick at an appropriate level, rather than hassling and when you're coming back, but also not leaving people to feel excluded from work. I think culture change does sometimes bring resistance. That's part of the kind of storming of the process, isn't it? But I think for most people, most of the time, knowing what the expectations are of you, what your obligations are, and having boundaries is quite a containing thing, makes people feel psychologically safe. So it's going to be a bit of a process of getting that kind of firmly established everywhere. The issues that are occurring in people's health are also occurring in our staff, because our staff are part of the population, aren't they? So health attitudes, exposure to media and those kind of influences, but also how health, thinking about health and thinking about illness. We just do that with part subject to the same influences, but we just come to work in a slightly different way, don't we? In a different job. So I think the problems that we're facing societally, we're also facing with our staff group. Again, having those ways of managing things will help. I think another thing is that we live in perpetual change in the health service. There's always a different agenda, isn't there, and a different focus. We have to be really good at everything straight away. And I think that a sense of low morale sometimes comes from being perpetually changing, having a perpetually fluid workplace or agenda at work, and that's down to us to manage and make sure that we communicate properly to staff groups and to be able to improve their sense of well-being at work. I'm sure there's some really high-level pieces of work ongoing about how to improve morale and retention.
Thank you, Jenna. I thought that really thoughtful responses, and Jenna's close to it. From an executive and from a corporate point of view as the trust, we absolutely acknowledge that our staff engagement is not where we want it to be, and that we've got a lot of work to do on culture. One of the things that we identified a couple of years ago was that we had underinvested in developing our leaders. And so we have put in place a whole suite of leadership development and what we're calling management essentials. So, for instance, up until recently, it was not essential for new managers to do performance management training or sickness management training. We just relied on them reading the policy. That's not good enough. We need people to be invested in. We need people to be developed. And we learn, don't we, from talking to other people. You know, we've talked about peer support and the importance of that in terms of our patients, but it's also equally important for all of us in work. You learn from other people. So we have addressed that. As Jenna says, it takes time. We've also been a trust that's been under a lot of spotlight, rightly so, and understandably so, for the last 2 years. And that in itself can bring its own pressures. And that can also affect an organisational culture. We're really well aware of that. We can't stop that. We are where we are. We will have even more pressures over the next 6 months with the Nottingham inquiry. And many of our clinicians will be involved in that, and that brings its own pressures. And we have been dealing with that for the past 2 years, because it isn't just people going down and giving evidence one day. If any of you have been involved in a public inquiry, there is an awful lot to it, and people have to be given the time and the support to be able to engage fully in that. So I suppose what I'm saying is we are absolutely not where we want to be in terms of the culture of the trust, in terms of staff engagement. We have put a lot in place to try and address that, but I wouldn't like to say at the moment we're succeeding. I think we've got a long way to go, and it's going to be a long journey to get there. And we will need the support of all of our leaders like Jenna and Rebecca to help us get there. But we need to make sure that we're putting in place the support that would help that to happen.
May I just, all of us want to.
Obviously something that we all feel quite strongly about. Thank you, Jen. And I think one of the things I'd like to add is that an awful lot of our staff experience quite a lot of vicarious trauma. We have hundreds and thousands of patients who have experienced trauma themselves, and listening to that on a daily basis and trying to support people with that on a daily basis can really impact the mental health of our staff. So we do have a really strong staff wellbeing offer, but that is still a really significant factor that we are very much aware of as leaders, but its impacts on staff on a daily basis. And sometimes that there's kind of risk of kind of physical aggression from our patients and violence to staff, as well as psychological violence to staff, as well as that vicarious trauma. So there are multiple different factors, as well as what Jenna mentioned about we're all living in quite a difficult society.
I was going to bring it back to the weights actually, and say that the conversations that I've been part of with the teams have been about that we've had vacancies to fill. We've really struggled to fill. We've struggled to attract really solid candidates from outside of the organisation. And I wonder if the scrutiny that we're under with the inquiry, it might be part of that. It might not be. But we've had to make some really tough decisions about, do we just get people into post even if they're not quite what we want and they're not quite ready, or over promoting people? Do we do that to be able to at least have people in post even if they're not of the standard or quality we might have wanted. So it's kind of pick your risk. Do you have your risk with the weights and the volume of people, or do you have lots of people in post who aren't really able to, without a lot of support, do the job properly? As we've been really good as an organisation at counting things and operationally being good at running stuff. We're moving into a spot we've got a greater eye on quality now. So I think we've just got to stick by our guns, and if we want to do things very properly and have those systems and those people be sustainable, we can't rush and we can't take shortcuts with it. So I think it contributes to the problems while we're solving them, but hopefully for a sustainable longer term better quality offer.
Thank you very much for your honesty. Can I just ask a supplementary question? If you're aware of obviously the position where you're at now regarding the surveys and staff satisfaction, have you got interim targets set over a period of the next 1 year, 2 year, 3 year, where you actually want to get to? And as of that would be a measure of how much you've improved in that area.
Yeah, so we set ourselves, the first target that we set ourselves this year was to increase the responses to our annual staff survey and we have a quarterly what we call pulse check, which is like a very much shorter survey. We were really pleased in June this year where we got a really good response to the pulse check. But when we had the main staff survey in the autumn last year, we saw a small increase in engagement, but not anywhere near where we want it to be. We don't yet know the results of that survey. That will be coming out in the next few weeks. So I suppose what we're trying to do is build the response rates, because if people don't, what we know and evidence shows is that the more people that respond, the more likely that is to be a positive response. People vote with their feet sometimes by not responding. So if you get a low response rate, quite often that is because people are not feeling engaged. So the first point is to try and get more engagement. And then alongside that, we look at the survey in detail, as do each of the leaders, because you can see down to your own team. I think it's if you've got a team of 10 or more, you're able to see your results down to your own team. So encourage our leaders to look at their results for their own teams. But overall, as a trust, we look at the results and we identify what are the 2 or 3 key things that Liz is telling us that we need to work on for the next year. We absolutely understand all of the external factors that go into this as well. And so we are not expecting miracles over the next, we need to see a steady increase in engagement, and as I say, we've set ourselves a target for this year. Not quite met it, but we have improved at least slightly. Next year it will be let's get it over the line, and then really let's look at those individual scores and what we can do to improve them. But it is, because this is so deeply ingrained and because of all the external issues we've talked about, we think this is more like a 3-year period. And at the moment, one of the things that we're just kicking off is some work on refreshing the trust strategy, because that's quite out of date now. It's 22-27 to 27, a 5-year strategy. But the world's changed a lot in those 3-4 years since it was written, and in particular it's changed a lot for Knox Healthcare. So we've got a new chair who took up post in January, and with his support we're working on, we're in very early stages of developing a new strategy. And I know from talking to him, but also the work I do as Director of Strategy, that whole issue about culture, staff engagement and supporting our staff is going to be really, really key in that strategy. And so we'll be able to, we want to consult with external partners, including the County Council, in terms of developing that strategy. We'll be able to tell you more as the year progresses on that.
Thank you very much, Matt.
Just for members, I'm conscious of time, so I've got Councillor Barlow and then Councillor Rich with some follow-up questions, and unless there is anything more burning after that, I will look to wrap this agenda item up as well. So if you do have a burning question, let me know. But I'll come back to Councillor Barlow, please.
Thank you, Chair. Can I just ask, so going back to your feedback from patients, do they feel that they're getting the care that they need you know, what are they telling you and how are you responding? That's just my first question. And then just maybe with regarding sort of, you know, thriving communities, when you talk about resilience, are we actually building into that general coping strategies, you know, so that children have to be realistic? You know, and I get what you said about thriving communities and wrap around and we'll have access. But we also know there are genuine inequalities in life. We're not all going to live in big houses with fancy cars, go on holidays. Some of us are not. Some of us are going to have more than ordinary jobs. You know, what do we do? Are we doing anything around that?
Oh, thank you very much. So if I take the first one in terms of feedback from patients, so councillors may recall that in 2023, Healthwatch carried out a review of our services from a patient perspective, and what came across clearly in that review was that patients don't always feel as if they get what they need. Some of it was down to the length of time they have to wait, but some of it was also down to the care that they received. We have put a lot in place to try and address those issues, and it's something Jenna and Rebecca can talk about far more detail than me in terms of both from a local mental health teams and also from an inpatient point of view. We're really trying to do, you know, the you said we did, we're really trying to work with our patients. We've just developed a whole new participation strategy, which is about how do we make sure there's patient leadership from involvement in their own care plan writing, which should be really, you know, basic, shouldn't be that they should be involved in that, right through to having patient leaders in services, working in services and helping to develop services. And we've been very much supported in some of the work that we've been doing through having some experts by experience and shining a light on our services. We've recently recommissioned Healthwatch and asked them to do a follow-up report looking 2 years on, 3 years on, more or less, to see whether there is a difference, whether people are feeling that difference, and whether we can see that patient experience has improved. So that is we won't have that report for another few months. They're doing the field work in the next 2 or 3 months, but that would give us a bit more of a check on, you know, are the improvements that we think we put in, are they really resonating? Are they really being felt by the people that use our services? I know, short of time, but I think, Jenna, it might be worth you just talking about what you do in the local mental health teams to look at patient feedback, and Rebecca in inpatients.
As the new matron posts across LMHDs are part of the quality line rather than operational. So we've picked up patient feedback, patient complaints. We've got really good links with PALS, excuse me. And as part of the management and oversight of quality in the LMHDs, we've got a couple of different reporting systems. So we bookend our week on a Monday with a system called Safe Now. I don't know how much of this has been explained. I don't want to patronise anyone, but I also don't want to be too detailed. So we've got Safe Now at the beginning of the week, and then we've got the patient tracker list at the end of the week, and that kind of bookends with quality and operations. So at the beginning of the week, in the quality meeting, we look at are there patient whose care is falling outside of our expected norms? So that's looking at some of the weights, looking at all sorts of different things that get thrown up on the report. But we've added audit. Are we doing enough care plans, but are they of sufficiently good quality? Risk assessments, are they of sufficiently good quality? And complaints and feedback have now been added to that list. And it's a really new meeting, it's a really new way of working for all of us. So we're trying to build slowly on it, but that is going to be part of those discussions. They then get fed up. There's a whole kind of track that information takes. So we pick that up weekly with each of the individual teams, and then we feed that up through the quality line for the patient quality experience. Thank you. Line which goes kind of right from kind of through director level right up to the execs. I guess that you'll see that information very differently to how we gather it on the day on the Monday. But there is I've got quite a lot of confidence in that meeting strategy, and that because we're getting it weekly now, we can see themes pop up. Is there something about the time of year? Is there something about a particular team? How do we relate it to absences? We've got a really quick way now of being able to keep an eye on those things. complaints are slightly different because there's something normally quite granular about that. Some of the case feedback that we get is, I wasn't seen on time. We don't know who that's an anonymous submission. We don't know how to do anything with that other than pick up the themes. But for complaints, we can be really quite a lot more granular about that, and that sits with us now too.
So I guess from an inpatient perspective, we've also been able to work with the National Culture of Care programme, which is very much looking at engaging patients and also making sure that we're trauma-informed, autism-informed and co-producing. And so as part of that, we do you said we did boards on the ward. There are weekly patient forum meetings. Then again, much more focus on the patients being able to be a lead and a true participant in their care. One of the wards at the moment is trialling patient-led ward rounds. So instead of historically, the consultant would lead the ward round, patients where they feel able to, with support, are able to lead their own ward round and look at what they want to get from the ward round rather than it being a done-to model. So we're very much trying to support with empowerment and very much that patient engagement. I noted one of the points was around what are we doing with young people and coping strategies, and I just wanted to pick that up very briefly. And a lot of the work that is done in both CAMS and the mental health support teams is very much looking at coping strategies. So if they're looking at CBT for anxiety management, for example, they'll look at helping somebody to understand why they're experiencing what they're experiencing, but then also give them strategies to help manage that. And those strategies can be lifelong for people. So we're giving people the tools to be able to manage their own conditions longer term. I can't speak about expectations because that's very individualised, but yeah, the coping strategy stuff is there.
So, if I may, Chair.
Yeah, quickly, please.
Yeah, just pick up about the broader community resilience. So I think Rebecca's really helpfully picked up almost the individual resilience stuff. And I think the Thriving Communities programme is around thinking around how we build up the more of the community resilience. So some of that might be linking into valuing the voluntary community sector, as Councillor Dodd has previously articulated. Some of that is around working around communities that might be at high risk of flooding, and some of that is around thinking around what assets we've got within our communities to build that more community cohesion, increasing volunteering, increasing those social connections. But conscious of time, I'm very happy to have some further conversations offline around that, and very happy to inform this group around some of the work around Thriving Communities work. As mentioned, there is going to be a broader conversation with elected members around how they can support and help shape some of that. So I can work with Democratic Services in terms of if there's anything we can do to support that conversation.
Thank you, Chair. Thank you for that. It was just that I've just thought if you develop coping strategies, you're going to prevent problems in the future. This was my point. Thank you.
Councillor Rich.
I'll try and be as quick as possible on this question because the Chair's been a bit impatient.
I always am.
But anyway, what I was going to touch on Councillor Dodd's point about the NHS relying on short-term charity funds, grants to deal with the crisis, and they're not having proper funding, like a long-term proper support mechanism instead of like a short one. Because there's a lot of charities out there in Nottinghamshire, fantastic, but you know, they only can do so much, let's be honest, and I think that the NHS can do a bit more than just a few helping support and expecting volunteers to do as much work as possible. Thank you.
Yeah, I completely understand what you're saying, and as somebody who has run a social enterprise myself, I know all about the pitfalls and the difficulties of relying on short-term funding. So I did start a couple of years ago a third sector commissioning group, which was really looking at how we can work better with our voluntary and community sector, and avoid those pitfalls such as short-term funding and other pitfalls in terms of how we set about working in the voluntary community sector, and together with members of the voluntary community sector, and I had particularly VCS colleagues from across the county involved, mostly the chief execs of the CVSs. We've developed a bit of a kind of charter, I guess you call it, about how we would work together. Sadly, what's prevented me taking that work forward as much as I would have liked is the fact that our own funding constraints in men's health care, which have not allowed us to take forward the work that we would have liked to have done in terms of working with our voluntary sector and in short, not having the money to commission anything that we would have liked to have commissioned. What I think we need to be doing now, and this is where I've got to with working with our voluntary sector colleagues, is thinking about, as we move towards neighbourhood working, and it's its infancy at the moment, we as in health and also I would suggest councils, we need to think together about how do we really bake in the fantastic and unique role that the voluntary and community sector plays, and do it in such a way that makes it sustainable for that voluntary and community sector. And I don't think we're there yet. I think we've got a lot of work to do, but I think we need to make it a fundamental pillar of the work that we do in neighbourhood working.
Yeah, thank you. Okay, thank you. Well, I will look to start wrapping up. I'm going to indulge in a couple of questions myself. I'd really like to get the members in first. I'm going to tread very, very carefully and lightly on this question because I don't want it to come across in any way insulting. However, if I go back to our last scrutiny meeting, it was on endometriosis and gynecology, championing women's health. It was championed by Councillor Rich, who brought this to us. I was very mindful, it's quite a male-led committee. That's just how democracy falls. I don't get to choose who comes on this committee or who's elected by the general public. However, I was very mindful of that. So I invited all the female councillors to come and participate if needs be. Didn't really get a massive uptake, but I wanted the women's voice to come forth in that session. Today we talk about men's mental health. And this isn't a criticism, but as the general public will see, I'm pointing at the screen there, but obviously it's recorded. But the general public will see that there's a panel of 5 women come to present on mental health. Very capable, you all are, and you really champion the cause. So, I'm really, really pleased by that. But for the general public, they may see that there isn't really that male voice championing men's mental health. So could you give assurances in both organisations to the general public as to how the run-of-the-mill man that's out there is really being championed in this conversation, and how their needs are being taken on board and help, sort of help to design, the service outcomes for the future?
I take your point completely, Councillor Robertson, and I know that unfortunately one of our male colleagues that was wanting to be here today was unable to be here today. And personally, from a very personal point of view, I'm the mother of 3 sons, and they are now all in their 20s. They've grown up locally. I've seen the challenges that they've had navigating that move into adulthood and continue to have. And so it is something that's very, very dear to my heart. I don't have daughters, I just have sons. So I tend to live in a very male-dominated household. And as I say, it is something very close to my heart. I also think that in workforce terms in Notts Healthcare, we actually have a really good, I don't have the stats to hand, but we do have a good prevalence of male staff, male clinical staff, and I'm talking about nursing staff and medical staff, and also the associated staff. I don't know if Rebecca or Jen want to comment more. And then finally, I guess, as I say, we do have colleagues that would have liked to have been here today, but unfortunately we're unable to make it, that would have been able to do it. But we can absolutely guarantee to you that we do take this very seriously. We do champion men's mental health. We have more men in our inpatient wards than we do women. And whilst we're very, very aware of the women's mental health issues, and there are some real complexities there, we are absolutely aware that if you look at any of our inpatient services, and I'm talking about our mental health inpatient services right through to our forensic inpatient services. So if I take Rampton, for example, you will see more men in those services than you see women. And so it's absolutely vital for us to be very cognizant of the needs of men and to champion those needs in the way that you've described. I don't know if either of you want to add anything.
So I guess two or three key aspects, I think. There's been quite a lot of focus on kind of young people, and rightly so. And we have a couple of male colleagues that are very prominent in that field, so who offer the clinical leadership to the services around that, and very much have a focus particularly on young men experiencing early onset psychosis symptoms. And so we have a lot of proactive focus on that cohort of young people, because we know that being able to intervene early really positively impacts their future trajectory. And the cohort for that presentation is mostly male. Also, colleagues that would have liked to have been here today, our Associate Medical Director for Mental Health is also male, and as is our Care Group Director, and we do work very closely, so we work to kind of share each other's views as well, so they have been very much involved in putting the content together, even though they haven't been able to be here to present with us.
Thank you, Councillor Robson. So again, you can get assurance from the Public Health and Community Team, the Board Council, that we will be championing the best services and support for men as we would do for women. I haven't got the exact stats in terms of our staff proportion. There probably is slightly more females in some of the social care workforces. And probably slightly more in public health and communities, but actually we do have a really good representation from the male gender as well. And we're really keen to have as many advocates as possible, so really keen to work with you in terms of if you want to continue to challenge us and push us on that. I think one of the key things that I would say though is within all of the work that we do, we really think about that equity lens. So we know very much around the fact that there are particular barriers that men experience in terms of accessing services, and that we need to deliver services slightly differently to engage that audience in a way that we might not for women. We know they have slightly different health needs, and we look very much in and around that. In terms of a lot of the suicide prevention work, a lot of the work is done through a co-production lens, and we know that many of our survivors will also be from the male gender, so we absolutely link those in. In terms of some of the specific examples, there's one in the paper which talks around how we are flexing our lens, thinking around how we might work with maybe sports groups in a slightly different way. So there's an example around how we're working with Nottinghamshire Forest Community Trust to deliver healthy goals in Ashfield and also in the city. And we know that that's going to have a particular lens around male attendance and very well for females. So it's just to give you that assurance that there will be specific things depending on the intervention that we will do to make sure that we are targeting our male counterparts alongside females.
No, thank you very much for that. But like I say, it was very much to sort of give that impression to the general public, because obviously we're here and we see, you know, the work that you do and the answer that you bring forward, and so we appreciate that. But it's just to make sure that the general public also knows that the male voice is being represented strongly. Just one very quick one from me. So I've seen the recently published NHS 10-year health plan for men. Very interesting read. And the bit that I struggle with, and it's something that it again goes back to that you know, male voice, is around the addressing societal norms, and it comes from a government commissioned report about changing gender norms, engaging with men and boys, and it suggests that the norms for men and boys to appear strong, in control, and reluctant to show vulnerability can hinder emotional expression and help seeking, contributing to poorer mental health and potentially putting them at risk of suicide. And I read that. But the thing that troubles me about that is, it's a government commissioned report that always, you know, sort of gets the heckles up. But the fact of the matter is that's polar opposite to how I consider myself as a male. I like to think that I'm quite strong, you know, that I don't show vulnerability, but that's just part of me. And what worries me is that there's a whole section here talking about how we address societal norms to change how men look at themselves, or how society looks at them and how we deal with their problems. And for me, you know, I don't know whether this is something you can really give a steer on at this level at the moment, but it makes me worry that we're going down a route of trying to deal with what society perceives is a norm that needs changing, and what the knock-on effects of that would be, because I would very much say, yeah, as a man, leave me alone. You know, I'm quite happy and I get on, I've got enough things to cope. But I also understand that not every man's like that. So it's how we get the nuanced approach to supporting men who need it, whilst also giving the normal societal frameworks of going to the pub and having a drink. Councillor Dodd and I, we went to the rugby at the weekend in Retford, and we had a great time, didn't we? You know, and it was predominantly men, and we all had a good laugh. It was good for our, you know, social and mental health. You know, so there's all these things out there. And just, you know, I'm just interested in how we get that nuance, so we don't just pigeonhole every man as needing a crutch in society, and those that need it get the focus support that they do need. Yeah.
Sorry, my thing's not coming on. So really good point, and I think if we go back to what we're seeing from an evidence-based point of view, so you will have seen this through the evidence that Jan and the team have seen today, we know that there are barriers and stigma associated to men accessing support at an earlier point. So you've seen in the evidence today that there's a higher proportion of women accessing community support, but you're seeing a higher level of males that are accessing, needing that crisis support and that more complex intervention. So the evidence is suggesting that males are not accessing support as early as women, and that they have slightly different needs. So I think there's something for me around thinking around how do we create a community and a population that supports that it's okay to not be okay. And I think there are differences in how men and how women interpret that. And I think that's some of the messaging that we're really keen to build on and grow, but also really understand from a male perspective. I think some of the work that we've done around the suicide prevention strategy has really changed our thought around how we should address that approach. So when we did a lot of the work a few years ago, one of the key messages that came out is we need to be able to be talking around suicide prevention and how we can support each other in these spaces. Now, we weren't expecting those individuals to be as open and honest and come out in that way. So for me, there's something about how do we work with men to understand what are the barriers that if they are not feeling okay, that would allow them to feel more comfortable to access the support in a way that's right for them. So I suppose it's something for me, not necessarily about thinking that you should think this way or you should act that way, because that's a very individual thing. But there is something around wrapping around our men in a different way to give them that safety net that if they need it, it's there and they know where to
go. I think Liv's made absolutely the right point, and nothing more to add. The only thing I would say is that it's really important to us that each and every patient that we deal with is dealt with as an individual, and that we have the care plan that's appropriate for that individual.
Okay, well, I think I'll wrap up there. I won't keep handing you with my probing questions. I just really want to thank you, for the content that you brought today, but also sharing the awareness of the services and what you're delivering, and thank you for delivering those services as well, because it does mean a lot to men, surprisingly. So I want to thank you all very much for that. And really, without anything else to add, I will move to our recommendations. Recommendation 1 would be that the report be noted. Yeah. And recommendation 2, that the feedback of members on the support available in Nottinghamshire for men's mental health and prevention be noted. Yeah, lovely stuff. Okay, well, that's it. So if you do wish to go, we're only going to talk about the work programme very shortly. So thank you for your time and your input.
Thank you very much.
Fantastic. Thank you very much.
Thank you.
Okay, so last item for the committee, the work programme. So the main highlight in respect to the work programme is that we're arranging a discussion on the impact of service transformation, and we will have the details of those arrangements in due course. I would also, Catherine has very kindly advised that in February we do have some flexibility on the programme, so if there are any items, I felt like you were looking at Scone then. So if there are any items on the work programme that you may want to see brought into February, we can't make promises because obviously it's having to invite people to attend. But if there is any topics that you do wish to see brought forward onto that meeting, then please either let myself or Catherine know, and we will look to try and arrange that. So has anyone got anything they wish to add with regards to the work programme? No? Okay, so we'll proceed to the recommendations. That the work programme and scrutiny priorities be noted. Thank you. And that authority be delegated to the health scrutiny lead to update the work programme as appropriate in consultation with myself as chair, the vice chairman and representatives of the relevant partner organisations, with any changes reported to the next meeting. Yeah. Okay, all that remains is for me to thank people who've already left. But I do thank them because obviously this is recorded. So I thank the members of the ICB and also the NHFT and also Viv and Louise as well for attending today. And for yourselves for the contributions that you brought, because I thought both items were absolutely fantastic. So without further ado, I'll call this meeting to a close. Yeah.
Thank you, Chair.